So, hello everyone. My name is Gorhar, and today I am very privileged to be interviewing Andy McDowell from Tulane University. He is an assistant professor of anthropology at Tulane University. And I had the privilege of reading his new book called Breathless, Tuberculosis, Inequality, and Care in Rural India. And so, without further ado, instead of taking up all the airtime, I will let Andy introduce himself and his book.
Hi, Gurur. Thanks for having me. It's really a lovely opportunity to chat with you and the others in the Shift TV program about a little bit of my work. I'm a medical anthropologist. I teach at Tulane University in New Orleans in the U.S. And I've spent the last it's about 15 years of my life working with people in India, both in rural and urban India, trying to understand how TB care works out there, the sort of ways that tuberculosis moves through social life and how people deal with it as a fact of life, but also as something that they um, would much rather avoid. So I've been trying to work over the last few years to think about how we can speed up time to diagnosis and high quality diagnosis. I've been really fascinated in how people care for each other in families and in communities, and also in the ways that we might think more about the private sector in India and their involvement. So I've been doing a lot of research in India. I've spent a considerable amount of my life there, and this is the output of one of those projects. Many of the people who are part of the Shift TB collective have been essential in doing this work, and I'm very grateful to be able to both share some of that outcome with them, but also to acknowledge their huge impact on my scholarly trajectory and the ideas that are here. So I hope some of them will see some of their ideas represented.
To start off, we would like to ask you what inspired you to write this book? And you could tell us a little bit about it as well.
Yeah, well, I first sort of began spending time in Rajasthan when I was 20, which has been quite a while, judging from the gray hair. But I was really fascinated that tuberculosis in a small community, much like the one I grew up in Iowa, the community, not the epidemiological issues, was really quite common here. And people were still not just getting sick, but also dying without being diagnosed or without access to proper care. And I found this to be a real and essential question. The only reasonable thing to do with such a question would be to get a PhD in anthropology, of course. So that's what I did. I was able to spend about 2 years living in the small community that I call Ambawati in the book, and trying to understand how people were dealing with TB, both how and why it moved through their community in particular, how they interacted with health systems that were ostensibly built to help them, and trying to understand how people thought about the ways that illness might be affecting their lives, but also how their lives might be shaping their illness experiences. So this was, of course, a PhD dissertation, and one that had a lot of audiences, right? There was the folks who were interested in South Asia and what it might mean to study rural life there. One audience was the folks in anthropology, and trying to understand how social life and disease interact, and one in public health, right? Thinking about TB as a real and important social problem of our time, a biological and social problem of our time. And so I started to write several different iterations of this book. I wrote one for the anthropologists of South Asia that was about caste and the way caste was connected to tuberculosis. I wrote one for folks in public health, and how people thought about health behaviors. And actually, I really hated that one. I hated that version of this book because it reduced the people that I knew and cared about as they were dealing with something really difficult and doing so often with some success, but usually with their head held high into examples and case studies of what should not be done by TB patients or by public health programs. And I thought, this is precisely what I don't want to do here with these people who have shared a huge part of their lives. Now we have this 15-year relationship with me. I don't want to reduce them to simple public health case studies. And so um, I decided on this version of the book, which is centering on breath, but also the ways people talk about breath and tuberculosis, because it allowed me to sort of to present um, tuberculosis as something that's really, really important to people, but not the only thing that's important to them. To show how this disease, which occupies much of our community's collective space, was a part of their life, but it wasn't everything. And I wanted to be able to highlight how those other things intersected with it, and how those other things made TB as an experience the way it was, but also that people can be happy or be sad or get in fights with their neighbor and deal with tuberculosis at the same time. And so by doing that, I started to sort of see a way, I thought, that would allow me to kind of connect social life and tuberculosis in a way that didn't make one more important than the other, right? Because what I think the book shows is that they're both really important. And if we sort of see one as the dominant part of our paradigm, we miss something important about the other. So from three audiences and trying to say something important to all three of them, to two ways of thinking about tuberculosis and social life, came this conundrum that I've had to try to weave through. And I've done that by thinking about two important concepts. One is this idea of atmospheric care that I think we'll come to in a moment, and the other as the kind of ideas of an atmospheric entanglement that allows us to think about how we're all connected, right, through air, which is essential for the transmission of tuberculosis, but also how breath and breathing modulates that connection. So the sort of big take homes for the book that I wanted folks in the TB world to start to think about was, how do we imagine or care in a way that attends to both the social and the biological. And I found that people in Ambawati were already doing this, right? They were caring for spaces, they were caring for the sort of exposures they had through breath, they were caring for family members by making them comfortable and by taking them to hospitals, but often they were thinking about spaces, which moved care away from just the individual to a larger collective, which I thought was really essential to share with our community.
To the next question. This one is from Charity, who is from the University of Waterloo. She asked the following question. She asked, to what extent do researchers need to go to build relationships with the communities they work in? How else can qualitative researchers and social scientists who do not have these experiences connect with the communities they are working with?
Yeah, so I'm an anthropologist, a cultural, social, and medical anthropologist, which means my method is essentially going to a place and being there for a very long time. This is now, for me, a 15-year engagement in this place. I was just there a few months ago. And part of the ways anthropology works is that anthropologists use their own body, their own self as a tool, right? We share experiences with people, we come to know them, we chat, we have tea, we have we go for walks, we do all kinds of things often that don't make it into our text because no one wants to read about the time I went for a walk. But the fact of the matter is that we come to know a place through our own eyes, right? I don't think as an anthropologist that I know Ambawati as my neighbors do. I can't, right? I have a whole different set of experiences and histories that I bring with me. But I'm able to sort of draw from the stories they tell me or the things that happened alongside me to begin to understand what it might be like to live from that place, at least from my sort of cultural categories or the training I've had as an anthropologist. So I think that coming to know and be a part of a place, even from your own perspective, which is the only one you'll ever have, is really essential. Now, Charity's question also asks us to think about what are the other ways qualitative researchers might come to know a place in that sort of intimate way. And I think this book is rather an intimate story of TB, despite the fact that luckily I didn't have to experience TB while I was there. But what I think one thing we can and need to do is work with researchers from that place. Many people around the world have a strong capacity for research, and there's no reason that we as qualitative researchers can't engage. The other thing that I have tried to do is to work really closely with students. in the areas where I'm interested in thinking with and in working as a researcher, because students often have their own important perspectives and their own sort of ways of sharing intimacy with communities that they may not have the social science tools, but I can give them those, right? That's what I can bring to that. So I think that these sort of experience near perspectives are really essential. The other thing that I think we can do as qualitative researchers is listening. Learning languages, listening are really, really essential. And I think that that's where anthropology can bring an important contribution to the social scientific study of TB is this emphasis our discipline has on like listening and taking seriously the ways people talk about things. Um, so I don't know that there's an easy way to sort of sneak around having lived there for a very long portion of my life and done laundry from a hand pump and you know walked through the mud with people. But I do think that engaging folks who are students or scholars in the area that you want to learn about is really, really essential. And it's part of a broader paradigm to think past the kind of colonial legacies that are part of global health. And it's the essential work, I would argue, of our generation to figure this out. And hopefully what Breathless is also trying to do by bringing other categories to that conversation.
So I will now move on to a question from Justin Denholm from the Royal Melbourne Hospital. So there was a moment, I think this was in the mud chapter, where
Mhm.
you are drawn into being complicit in not disclosing a history of previous tuberculosis treatment in order to hopefully facilitate better treatment for the patient. You break down each person's motivation and perspectives for doing this. Can you tell us a bit more about what the emotional experience of that episode was like for you?
Yeah, so let me tell you a quick bit of the backstories. My friend Dolat Singh had been sick with tuberculosis twice before we went to the hospital together. Both times he had been diagnosed and in treatment, and both times he had been called away for a family emergency to South India where his sons worked. He has, I think, four sons. And they all lived together there, and they would kind of, quarrel as four sons who live in the same house might do. And he would need to go to negotiate a kind of, or at least have a family meeting. And he very often, because the paradigm in the public system there was that the medicines must stay at the clinic from which the patients prescribed them, um, or at least the nearest clinic to their home. He couldn't stay in TB treatment and go. This policy is more flexible now, but in 2012 when this happened, that was the case. So in each case, he went to South India, leaving his TB treatments behind. Um, he would be better for a while. He would fall sick again. He started TB treatment again. The third time this happened, he was pretty sure it wasn't TB, and he got quite ill. Everybody else in town was pretty sure it was TB, including me. And so we all sort of encouraged him to visit a doctor. Eventually, he did. His family decided he should go to the large TB hospital about 4 hours away. It was an old sanatorium started by the colonial government. Um, One day he decided to go. They came back home after seeing the local clinician who gave a few pills and told him to come back another day. And the next day we all decided to go to the hospital. He asked if I would join them. I was invited, I think, as a patient advocate, but also as a guy with a debit card and also as a person who could speak English. I mean, there were a lot of reasons why he would have wanted to invite me. He also, we were close friends and he knew that this was something that would be useful for my work, right? So we all go to this big hospital up on a hill outside of a large city in South India, and we had forgotten that it was Sunday, and the hospital closed at noon. And so we waited around at the outpatient ward for a while. No one came. A man came and told us that it was closed, and we would have to either go to the emergency room or go to the doctor at home to get admitted to this hospital. Now there were three of us. The evening was falling. My friend was clearly not in a state to be able to go back, even to the city, let alone his home 4 hours away. So off we go to the emergency room, and the emergency doctor, very kind young person, asked the sort of basic questions one would ask of someone that they're going to begin starting at least TB treatment or working up a diagnosis, and asked my friend Dalit Singh if he'd had TB before. We'd already experienced some unpleasantries with a nurse. We were sort of asking for an exception to be admitted outside of the normal channels. Things were, well, for lack of a better word, touch and go. It was unclear what would happen, right? And so Dalit Singh very quickly said, "No, I've never been in TB treatment before." The doctor asked him again. He clearly was not certain that this was the truth. Dalit Singh said, "No." I thought, "Oh God, what am I going to do?" Right? Here is my friend who probably really does need to be tested for DRTB. Um, at the same time, the health system had shown itself to him and me by this point that it was possible that the doctor would have said, "Well, if you've already been in TB treatment before, go home and start from there." That would have probably been a death sentence, even just getting back home for my friend. Um, and so I was really caught, right, but between the sort of what is the right thing to do there, and I sort of in a flash said, "Well, a lot of his neighbors have MDR-TB," and the doctor sort of looked at me and said, "But he doesn't, right?" And then I I lied because, well, he said he doesn't have MDR-TB, and I said, "I don't know, no." Um, so this, I think, is a really telling event. It was one that weighed heavily on me and continues to weigh heavily on me. Luckily, some of that weight has been lifted by the Letzing successfully completing drug sensitive TB treatment and doing well. And I got to see him a couple months ago. So um, part of it is sort of resolved, but I think what it shows us is this real the real precarity patients or people who are coming to care feel, right? That there was no right answer for Dalit Singh, I think. And I think that was something I really wanted to highlight, that when we think about patients or people who are infected with TB as particularly at the time the discussion around drug resistance was really about patient resistance. And so when we think of it that way, and that's one of the themes of the book, we make we make patients feel really unsafe and uncared for, and we do a poor job as a people interested in helping them, right? I have no doubt that the young physician wanted to help him, but the risk seemed way too high at the time. And also, these people were my friends. I didn't want anything bad to happen to them, and so I think anyway, this to me suggests that this suspicion, which is no longer the word we use, thankfully, around people with TB, it has a real impact, right? Not just on people's lives, but also on the research and the way we talk about that research. And we are, as a collective, I think, complicit, just as I was, in these kind of moments where um, thinking about the practical and the ethical are really, really complicated. So it was not my proudest research moment. I would probably do it again if that were the case. It was very unclear at the time if he would have told the truth, what would have happened to him. And I
Yeah,
think the risk for the family was too high. And I think that's really, really telling about a health system that could use a little help. Um,
yeah, absolutely. I mean, I don't even think that's a type of narrative that's limited to um, tuberculosis in rural India. I've seen that with coming from a Canadian context, I've heard stories of that where, let's say, people from more marginalized backgrounds have to kind of adjust their story in a way that will be palatable to the doctor who's caring for them. They're working on such limited time, resources. It's not even it's not the physician's fault necessarily. It's just how it's built, the system.
and I think to just follow up on that, I think that that's the other thing that is really essential to think about. Patients lie to physicians all the time, everywhere. I lie to my physician, don't tell him. This is a part of this shows us how much power the medical system has over patients, that we think that there's a right answer, right? that we're worried that there's a right answer, that if we tell the wrong answer, we might not get the kind of care we want. And so I think this is, as you said, this is a much broader question about power in medicine, but it's also really important to think with that as qualitative researchers, right? That probably happens when we ask our interview questions too, right? And that's really essential to say, okay, well, what sort of power dynamics are at work in an ethnographic interview? What sort of questions are at stake here? What kind of risks might the person I'm talking to feel as they're being asked questions by an anthropologist who has relatively no power in a health system, but they don't feel that doesn't necessarily make sense to them. So I think that we it points us as qualitative researchers to this question of like, well, what is a lie even tell us? Usually it tells us a lot. And so it asks us to be a little bit less naive about interview data as well, which I guess is the upshot of this kind of harrowing thing that happened. Um,
Definitely. Now, moving on to a question from Nora Engel from Maastricht University. She asks, for the TB community, the way you've described the atmospheres within the book, these are unusual words and ways of describing TB and TB care. What would you say is the value of this type of anthropological gaze on atmospheres and these unusual words for the TB community? What do you hope people could do with these insights?
yeah, well, I guess there's a little bit of background that needs to go in for that question too. So the book is organized around what I've called entanglements, right? So the things that people think of TB as connected to, the things or the material things they use to talk about TB. So there's a chapter, the one we discussed earlier on mud, was how Singh talked a lot about how the mud in the community had affected his body and made him sick. But for him, it was both a metaphor of kind of being stuck, but also like actual mud, right? And so the book organizes itself around a lot of these things: dust, air, clouds, breath, um, afterlives, and forests. And so in each of these, what I was trying to do was to talk about the concepts and ideas people used in this place to make sense of TV. So one of the reasons I did this is because each of them could have been read as each of those chapters could have been organized around a different public health oriented term, right? So for example, the chapter on clouds, which is one of my favorites, is also a chapter about stigma, right? It's a story about how people think about the kind of movement of TB and its connection to moral behavior, but also to others, right? We could have called that stigma, but it's not. It's not, right? And so often, I mean, it is, but it's not. And so often, when we come in with a concept, we only see what that concept shows us. And one could have written around stigma, but one would have just gotten a bunch of people who are being mean to each other, which was not the case, right? Sure, they were thinking about what TV might tell them about other people and their practices in their life or their moral personhood, but they were also thinking about the ways that spaces are imbued with morality, right? So what I think that these concepts do, or at least these invitations for public health to think about our concepts through others rather than our what our concepts tell us about others, are really essential. So one of the other things I tried to do was I wrote a chapter on uh, about a man who lived at the edge of the forest, and whenever I would speak to him, he was experiencing DRTB at the time, and I wanted to understand how that happened and how he lived with this. We would sort of sit at the edge on a cot on the hill that he lived in, overlooking the forest, and we would talk. Um, and one could have read those stories as a kind of patient pathway narrative, but they weren't, right? Because they never moved in a straight line. They often went in many different directions. He got lost, I got lost. What they were was a kind of forest, right? And so another way to think about a pathway is as a tree. And so what I think pathway metaphors show us, they ask us to miss the forest for the trees. And so I wanted to really sit with, well, what happens when we sit with the idea of DRTV as not a tree but a forest? A whole bunch of things, bacteria, people, pharmaceuticals, ideas, practices that are kind of clumped up together and need each other to live and survive, sometimes one in the shade of the other, and change. Well, what happens when we see it that way? And can we understand uh, bacterial resistance? Can we uncouple bacterial resistance from social resistance? Because my friend and I, who were sitting at looking at this forest, had done his best to get care. He'd done his best to stay in care. Um, but it was this forest of other things, right? The ways that TB could reassort itself, but also reassort social categories. And so I wanted to think about what would happen if we changed our concept. We could still use the patient pathway metaphor and the data we got from those kind of narratives, but we would have to listen to them differently. And so that's what I wanted to do by saying, well, okay, what happens when we think of DRTB as a forest? A lot of complicated processes happening at once and doing something that have to be understood with each other. The other concept I try to bring is a real attention to breath, right? Like what is breath? And so I spend perhaps a slightly too long chapter thinking about the ways people talked about breath and the ways they connected it both to their sense of a self, but also their sense of the world, and how those frames on breath actually shaped what we in public health would also often call patient behavior, right? And because the person I call Siddharth in that chapter, if we were to read that chapter through a kind of straight public health lens, we would think of him as just completely erratic and irrational and lost. We would fall into many of these traps that we've set ourselves as social scientists in TB or as public health workers in TB, that patients are lost and confused. But if we use this lens of breath that took me far too long to understand this, what was actually going on, we can see that his actions are being organized not through a kind of helter skelter, doing whatever, but really about around thinking about what breath is and how to work on it, how to fix it, how to deal with it. And so he and his family become, they're no longer sort of patients who are not providing each other care or not accessing care. They're not delaying care, they're caring, um, but they're caring for breath as they see it. And how do we think about interventions that can um, foreground breath, not just as a sort of vector of disease as we often do, but as a connector and as a way of understanding how people think about their body and their world. Finally, I write a whole chapter about air, and air um, could have just as easily been about contagion, right? We could have said this is about contagion, but what I learned is that it wasn't, right? It was about care. When people were talking about air, they were really talking about the ways that bacteria, but also ideas and atmospheres move through the air and how to manage that, right? So if we it points us, I would argue, to the ways we should think about connection and contagion together, which I don't think we do enough of. So each of these words that sort of don't look um, like the normal words we use to describe TB and TB care are for me anyway a new way to think about those concepts that we've been using for a while and think about what other ideas and ways of understanding TB might say to them, rather than what they might show us about how people who are different from us think about TB. Because I'm not really that. I don't feel like that's very helpful. So what I think the book tries to do with these concepts is to move us a little bit past um, the kind of received concepts we use to think about TB, because they have strong biases. And frankly, I hate to say it, but they're not really working for us. And so it's up to us, I think, as scholars, but also it's up to us as members of the global community to start to think about um, new sources of concepts and ways of providing care. And often those are, as we know, going to come from the communities most affected by TB, and that's what this is. Um, what I would like to make a small caveat. I don't think these are universal categories. Just as I don't think stigma is a universal category, I'm not advocating we use clouds as a universal category to understand TB. I'm simply saying we need to think about the kind of ways that social categories move and change, and that analytic categories can be developed to think about TB as a deeply situated particular experience of the kind of entanglement of bacilli, bodies, and social worlds. And I think that what I'm providing here isn't so much a conceptual language, because I don't suggest you go out and like listen for clouds in people's conversations about TV, but a kind of methodological orientation and an openness to really taking seriously how people who are dealing with this epidemic live through it, or sometimes don't.
Very valuable insights. I like what you said when we come in with a concept, we only take what that concept gives us. I think that's a really important framing that is perhaps missed in a lot of different disciplines. So thank you so much for sharing that. That's all for our questions today.
I'm really grateful for Charity and Nora and Justin and Jen and your questions. They were really fun to think with, and a great opportunity to consider, really what is this book saying to public health and to the broader collective of us thinking about social science and TV together. And I'm grateful for the opportunity to share